Hi all, thank you for joining Gradient Health Systems webinar this morning and afternoon and evening. We will give our attendees and panelists a few more minutes to join and we'll get started. Thank you.
Hello, morning, afternoon, and good evening. Welcome to the webinar. As we are continuing with this education panel, education forum, which have been useful for. So today we'll be going through principle of anesthesia for C-sections. We have our presenters from Nigeria and Tanzania. We have former SAPI based in Tanzania, working at the Mimili Teaching Hospital. But also we have Zanati, anesthesiologist from Zambia. And my name is Ansbet Sipetindebea. I'll be your moderator. But also we have some other panelists, Dr. Ndaba and Dr. Papicho. They will introduce themselves as we are moving on. So before we start, I would like to welcome Mariam to give us the ABCDs and housekeeping issues. Then we'll jump to the presenters. And once the presenters are done, we'll continue with the questions. So if you have a question, please write it on the chat box, or you can keep it and then you can ask at the end of the presentation. Mariam, welcome.
Great, thank you so much, Dr. Sweetman. I just wanted to do a quick welcome to all of you and thank you for joining our webinar this morning and afternoon. Just a couple of housekeeping items before we get started. As Dr. Sweetbert said, if you have any questions during the webinar, please use the Q&A feature to ask us or use the chat function as well. We'll also have time at the end to have our participants ask questions. The webinar will be recorded and you'll receive a copy of this recording after the webinar. And you can also find it on our website, gradienthealth.org, under the training section, or you can find it on our YouTube page, Gradient Health Systems on YouTube. As well as if you have any feedback or any topics that you'd like us to to cover in the future, or any feedback for this webinar, any questions, please reach out to customers@gradienthealth.org following this webinar, and we can connect you to our team here. I'll turn it back to Dr. Sweetbert, our moderator, who can get us started on the webinar.
Thank you very much, Mariam, and so I will welcome Dr. to start the first part of the presentation, and then Dr. Zana to take the second part. Thank you very much. Welcome, presenters.
Okay, good afternoon and good evening and good morning, depending on where you are having this talk. My name is Dr. Paul Mwasapi, as I've been formally introduced by our dear moderators. I am an anesthesiologist from Tanzania, practicing our teaching hospital at a tertiary hospital, Muhimbili National Hospital. I'm very happy and eager to be with you to engage in this topic, because I deem it to be so relevant and happens to be a core practice of anesthesia as we do provide these services to our beloved mamas. So in this topic, as you can see in your screens, that will be the roadmap. Again, we will talk a little bit about physiology and changes that do occur during pregnancy. And I will touch base with principle of neuraxia anesthesia, specifically for cesarean section. We'll go and discuss about principle of general anesthesia. I believe that will be another facilitator, and go and discuss about standard monitoring in obs anesthesia. Go. So why are we insisting on discussing a topic as ours today? It's because cesarean section is one of the most performed surgical procedure in our locality and even globally. And the WHO recognize or is acknowledging that there is maternal mortality and morbidity significantly burden, especially in lower and middle income country. And this is because of elevated complications that are rising during these processes. So today, as we go and discuss about cesarean section and the modalities of anesthesia that are involved, we are going to see in detail what is to be done and what is not to be done in respect to that. Go. Next slide, please. Yes, so many of the physiological changes during pregnancy are pertaining to the increased levels and titers of progesterone as a hormone, which in physiology causes few things to happen. Due to that, it normally relaxes the smooth muscles, and you can have your arterial dilatation and venous capacitance increase. Your blood volume and plasma volume also increases during this period. Cardiac output is also noted to be elevated during the period of pregnancy, and there is increased blood flow to various organs we are going to see. Next slide. So pertaining to these hemodynamic changes, we are going to see things like autocaval compression or compression of aorta and vena cavas. This commonly happened as a patient is lying supine. When they're lying supine, the major vessels, aorta and vena cava, they are sandwiched between a gravid uterus and a rigid spine. So there's a chance of compression to block the supply to other organs, and also to block the supply to the heart, commonly known as a venous return. The typical feature of this condition may be mild, as far as a mild hypotension, you might note a small and sometimes even insignificant change in blood pressure, but they can be as catastrophic as a total cardiovascular collapse, which can cause a patient to have a cardiac failure. But another change that happened, as we hinted, is increased regional blood flow. You can have increased blood flow in various organs, the first one being the uterus and the placenta. During the peak of the blood supply in the third trimester, the uterus is believed to be receiving up to a quarter of total cardiac output, which is a serious amount of blood that is supplied over there. But you can also have increased blood supply in nasal mucosa. This is an area of interest, especially if you are doing a nasal manipulation, such as nasal intubation or suctioning. You can also have increased blood flow to the skin because of vasodilatation. This in turn leads your patient to be susceptible to episodic hypothermia. Next slide. Also, the respiratory changes, you will have reduced FRC, functional residual volume. This acts like a temporary store of oxygen, especially during your apneic ventilation. You might notice your gravid patient, they tend to desaturate quick. This could be one of the reasons because of their stores being depleted. And this is because the anatomical changes that occurs during this period, the gravid uterus tend to compress the thoracic and to reduce its volume. You can also note an increase in metabolism and oxygen consumption. Under normal circumstances, an adult use somewhere between 200 and 250 mils of oxygen per minute, but during pregnancies, these tend to rise. Other marked changes are increase in tidal volume, respiratory rate, and decrease in carbon dioxide pertaining to hyperventilation or changes that occur during pregnancy. Next slide. In this slide, we show other changes that can happen in different systems. I'm going to hint some of the key changes that happen in different systems. In renal system, you can also notice increased GFR or glomerular filtration rate of more than up 50%. You can also notice glucosuria and other change pertaining renal and the urinary tract. You can also notice a frequency in urination due to reduction of bladder. In gastrointestinal changes, it is important to note that there is decrease in the gastric emptying time and increase in acidity due to different physiological change. In hematological change due to hemodilution of increase in plasma of more than 50%, it can cause your HB to come from 14 to 12. Yeah, but also it is noted that these patients in this group, they have hypercoagulability, although most of the coagulation indices stay within reasonable normal rates. Next slide. So what is your role as an anesthetist or anesthesiologist in providing care of these women? So first of all, it is important to note childbirth and pregnancy remains risky to both the mother and the baby. So this is an important care as you as an anesthetist to plan for these risky women during antenatal period on how to address various complications that can arise and cause morbidity and mortality. The role of anesthetist on delivery unit, it encompasses that of a peripartum physician. In most of our setting, as far as operative medicine is concerned, an anesthetist, we are expecting you to have assumed a lead role in providing care. And it is noted that on the normal delivery process, approximately 60%, so more than half of the women will inquire an intervention of some sort during this process. So adequate supervision requires anesthetist to be present throughout the conduction of anesthesia and administration of procedural sedation. This is the standard 1 WHO standard of practice, that you as an anesthetist or anesthesiologist to be present during the care of this patient. Next slide. So principle of anesthesia for cesarean section, preparation is the key. We need to prepare the patient, the equipment, and the drugs that are necessary. We are going to talk a little bit in details in different modes and special considerations that will be required in provision of different mode of anesthesia. You have also to conduct self-anesthesia, and not to act in silo, but to communicate your goals and targets and end meets of care to your surgical team and even to the patient. Monitoring of the patient is of paramount importance. We are going to see what are the minimum standard recommended monitoring modalities that are warranted in provision of care in an anesthetized patient. But at last, you need to document. In medicine, we have a saying, not documented, not done. So this is very important for at least reporting what happened during the procedure, for the research purpose, and even medical legal purpose, and for internal quality assurance interventions. Next. So the choice of anesthesia technique is quite an area of interest, especially when you are dealing with cesarean sections. There have been various school of thoughts. There have been various practice and experiences that have happened before. But now, most of the cesarean section are happening on neuraxia block in comparison to GA, although there are some cases that GA is mostly recommended. We are going to see them. But under normal circumstances, neuraxia block, especially spinal anesthesia, is highly recommended and remain favorable due to the level of expertise needed, the lower incidence of complication in comparison to general anesthesia. Next. So neuraxia anesthesia, as I've said, is currently the advocated modality, and it includes provision of anesthesia via a spinal, sub, or subarachnoid block, or epidural block, or a technique that combines the two. And as here, our current practice and our experience, even in our country, Tanzania, has shown that most of the employed modality amongst the three is the spinal anesthesia. Next. I think that is owing it being cheap and being easily done. That does not require high level of expertise or as a medical consumable involvement. So you might ask yourself, what is the benefit of neuraxia block in comparison to other modalities? The first one, there is an extended postoperative pain relief. This is because commonly the block lasts a period of 3 to 4 hours, and the cesarean section lasts a period of half an hour to 45 minutes. So it provides an extra cover of pain. Meanwhile, if you use the other modality such as general anesthesia, the moment you recover the patient, you have to think on long-lasting analgesia management. There is a relatively better preservation of cardiovascular and respiratory system stability, and it has noted to improve patient satisfaction, and less drug is involved and in lower doses. So clinically, the patient has reduced chances or incidences of succumbing to systemic drug toxicity in comparison to other modality. In the side of the fetus or a newborn baby is associated with better fetal outcome and higher APGAR score. And there is an emphasis of nowadays of maternal and infant bonding. In this modality, this can be vividly seen because the baby will be born in high score and quite active, and the mother will be awake to receive the baby and starting nursing the baby while in the theater. On the hospital and administrative side, is cost effective to cater for neuraxia block, specifically spinal anesthesia. Next. So this study, on this chart, you'll see different anesthesia technique, and they are stipulated advantages and shortcomings. I urge you to go through it. You can take a screenshot because it's populated with a lot of details. Some of it we have spoken, but at the end, in the interest of time, this webinar will be recorded and provided to you. But you'll be able, if you have any question while you're digesting on that, you can ask it on the end. Next. So yeah, this is the same thing. Just go next. Yes, so another area of interest is the pharmacology involved in neuraxia anesthesia, especially if you are doing it with conjunction with opioid. Those are the recommended dose. Like in our setting, the common dose that we use is 1 to 2 mils of a 5%. We use 2 mils of a 0.5% bupivacaine, meaning 5 milligram of bupivacaine per meal. But you can see there are different arrangements, such as 0.75, which will have 7.5 milligram of bupivacaine per each meal of the drug. And in this, the amount of drug that you're recommended to use is between 1.2 to 1.6. Just make sure this bupivacaine is hyperbaric to lessen the incidence of complications such as high spine and total spine. So we highly advocate for hyperbaric bupivacaine in comparison to its counter alternative isobaric or hyperbaric bupivacaine. If you're conversant enough, you can also use opioids, but here we use smaller concentrations in comparison to the systemic opioids that we use. Here, in case of fentanyl, we use somewhere between 10 and 25 microgram and 25 microgram. And so fentanyl, if available at your disposal, 2.5 to 5 microgram. And this can offer an additional benefit of analgesia to your patient. In case of fentanyl, 3 to 4 hours. Meanwhile, if you use maybe systemic fentanyl, it will last around 15 minutes. Next. Yes, so there is no medical intervention without a discussion of potential complication might arise. So the Complication of neuraxia block, they can arise from chiefly 3 areas. They can be related to your needle insertion. Such complication could be post-dural puncture headache. This is one of the common complications that arise post spinal anesthesia. When the dura is punctured, there is a chance of CSF leak, and CSF as a cushion between the meninges. If it's lost in a significant amount, it can cause nerve traction and meninges traction that could cause headache. But you can have block failure if you miss to empty your local anesthetic in the subarachnoid. But there is a chance of nerve injury, which is a minute chance, and like 1 in 166,000. There's a chance of backache, hematoma, 1 case in 220,000, and meningitis if you didn't apply a sterile technique. Other complications, they can be related to exaggerated physiological response toward your local anesthetic. So you can have hypotension and shivering. These are, most of them are owing to blocking of sympathetic effect of the body that can cause cardioaccelerator and vasodilatation and lead to hypertension. But you can have high block and other complications that related to intrathecal drug generally, such as pruritus, systemic toxicity, and nausea and vomit. Next slide. So how to avoid complications? Here is where you as an anesthetist or anesthesiologist, you have a great role to play. You can avoid a lot of complication, first of all, by preparation. Do adequate preparation before attempting your cesarean section, especially when it's in elective basis. So in preparation, you can prepare the patient adequately by doing a pre-anesthetic visit and interview that will check the history of the patient to see if they have other superimposed comorbidities and other significant past medical history. You can also prepare your equipments to tackle different complications. So put your bougie if you're expecting difficult airway, put your stylet, prepare auxiliary oxygen if you in a place where oxygen depletion can occur commonly. Also prepare drugs to cater for different emergencies. As we have seen, one of the commonest complications that we see is hypotension. So prepare vasopressors, your ephedrine, your adrenaline, your phenylephrine. All of those can rescue in case you get to face the complication. Other avenues that you can use to avoid complication is the safety approach and monitoring and communication. Next. So how do we prepare the patient? The first point is good IV access. Good IV access, why? Because we have seen our patient has a chance of succumbing to hypotensive episodes. So you need good IV access. And also this access could be, apart from fluid, vasopressor could be used to give other drugs directly to tackle some of the complications. Resuscitative equipment, you need your ambu bag by the side, you need a working machine, you need your laryngoscope to be working, you need your stethoscope. You have to make sure you can manage airway and provide oxygenation and make sure you make sure the patient is breathing well all the time, whether spontaneously or assisted using your bag valve mask or your anesthesia machine. And preparation also involve prepare yourself to be able to cater for general anesthesia. Even if your mainstay is neuraxia block, make sure you can provide general anesthesia. Why? First is if neuraxia blocks get to fail, you can go convert the technique to general anesthesia, but also some of the catastrophic complications such as total spine and high spine, they might require your intervention by providing general anesthesia. Next. So that was my last slide. In case you had any question, please write it in the chat box. We encourage questions in whatever language you want to use that is conversant to you. And on that remark, I would like to welcome Dr. Zainat to take you to the rest of the presentation.
Thank you. Good afternoon, good evening, everyone. I'm going to take the next section, which is on principles of general anesthesia in obstetrics. So whenever neuraxial anesthesia is contraindicated, unavailable, or patient refuses, general anesthesia is indicated. Some contraindications to neuraxial anesthesia, such as patients in category 1, cesarean section, like those that have a ruptured uterus, a patient with bleeding, postpartum hemorrhage, or acute fetal distress, citing neuraxial anesthesia could delay delivering the fetus and is rendered a contraindication. Patients in which neuraxial anesthesia has been attempted but has failed, general anesthesia is an indication. And then some certain group of patients with some cardiac issues, such as some valvular heart diseases, in which you can't also administer neuraxial anesthesia. So general anesthesia will be your option. However, because these are a set of peculiar patients, you have to ensure that special conditions will need more precautions. For example, you have a patient who has severe preeclampsia, who has HELP syndrome, so she has low platelets. So you have to arrange with the hematologist that you need some certain blood components, like you need platelets. So you need to prepare. And then you also need to prepare because you're going to deal with the patient's airway. And as Dr. Paul, the first presenter, mentioned that obstetric patients have difficult airway because of some certain physiological changes in pregnancy. So you need to be prepared. Also, you need to have your airway adjuncts, which I'm going to dwell on in the next slides. And then so preoperative assessment is essential. So we take a pre-anesthetic history. We examine your patient, you check for relevant investigations and you plan. You have to fast your patient depending on how the patient presents. If it's an emergency patient, you have to, when you're reviewing, you have to administer your prophylactic antacids. You give your prokinetics, all to facilitate gastric emptying. And then you make effort to ensure optimal conditions before induction, because you need some certain equipment when you're dealing with the airway. I'm going to dwell on that also subsequently. So can we go to the next slide? Okay, so the principles that you need good oxygenation intraoperative. So that means you need to ensure that you have your oxygen source is handy. It could be either in the form of pipeline oxygen or oxygen cylinder, or even an oxygen concentrator, because the World Health Organization and World Federation Societies of Anesthesiologists have recommended that oxygen should be made available for any hospital that is providing obstetric anesthesia. Then minimize risks of aspiration. So this starts from your pre-operative visit. You have to fast the patient, your pre-medications, and then even in the intraoperative period, you have to ensure you have a functioning suction machine. And given our peculiarity of having unstable electrical supply, you have to ensure that you have at least the foot pedal suction machine. And if you're fortunate to have an anesthetic machine which has medical gas-driven suction, that is also a plus, and it should also be within your reach. And then prophylactic antibiotics, because maternal sepsis is also one of the causes of maternal mortality. And as anesthesiologists, we also play an important role in reducing maternal mortality. Then pre-medication, as I have mentioned them. Then good perfusion of organs and uterus. So you have to ensure that you have a good IV access. You check your patient's hydration status, ensure that at least you have a urethral catheter in situ, your patient is draining good urine. These are all important principles. Then no awareness. Obstetric patients are at increased risk of developing awareness from because they have some peculiarities. They have a lower MAC, minimal alveolar concentration, and then the issue of avoiding giving opioids. So we'll try as much as possible to minimize that. Okay, the next slide. Okay, so airway management. Preoperative airway assessment is of paramount importance because failure to intubate and ventilate a pregnant woman is a catastrophic event, as both the life of the mother and the fetus could be lost. So at least at the preoperative visit or at the pre-anesthetic review, you have to do some airway assessment. You inspect the neck, look at the neck, whether the woman has a short neck, or you assess the mouth opening. How wide can she open her mouth? You inspect the tongue. Does she have a large tongue? You assess the myelopathy, and then you make the relevant plans to facilitate securing her airway. You ensure you have your difficult trolley handy, and then you have a senior person to review if you anticipate difficulties with the airway. And then in some cases, you might have to still go for neuraxial blockade if you find that it's going to be difficult, or awake intubation, even though this would require use of specific gadgets like fiber optic devices. So that will require a lot of expertise. So the point here is to always ask for help. Then ensure we pre-oxygenate, as Dr. Paul mentioned. They have decreased functional arterial capacity, so they are prone to desaturate rapidly during induction. So we have to ensure that we give them 100% oxygen at least 3 to 5 minutes before induction. If possible, if you can do it in the left lateral position, fine. And then in dire emergencies, then you have to go for 4 deep breaths before induction. Okay. Next slide. Okay. And then failed intubation could occur as high as 1 in 300 obstetric patients compared to 1 in 2,000 for all other individuals. And as such, rapid sequence induction is recommended for both elective and emergency obstetric cases because they are all considered as full stomach. And as such, you give the pre-calculated dose of induction agent, and your choice of induction agent will depend on the maternal hemodynamic status. If you are dealing with a woman who is already bleeding, your choice of induction agent would preferably be ketamine compared to sodium thiopental or propofol that could cause some further hemodynamic compromise. And then your choice of muscle relaxant, succinylcholine is preferred. However, in some certain conditions where it is contraindicated, rocuronium is the alternative. But we should note that with rocuronium, the peculiarity of rocuronium is that it has a reversal agent per se, sugammadex. But you should also note that we should ensure that we have enough of that sugammadex before administering rocuronium, even though I don't think it's not readily available, however, in our environment. But I'm just saying. Okay, next slide. So intubation still on the airway. If it's difficult to secure the airway, record pressure should be maintained all throughout. 100% oxygen should be continuously given and call for help. And it's safer to allow the patient to wake up rather than persist with the attempt. And if procedure cannot be delayed, consider use of face mask or laryngeal mask airway with the correct pressure, because LMEs still do not protect against aspiration of gastric contents. Okay, next slide. Okay, so this is one difficult airway management algorithm in pregnancy. So following induction and there's a failure to intubate, the next thing is to try to mask ventilate. If it's adequate, and then there's no fetal distress, okay, then you awaken the patient and then you re-strategize. You can consider whether you can give regional for the patient, or you could still intubate and then go on with the extubation over a jet sterlite or fully awake. However, if there's fetal distress, you still cannot ventilate. A surgical airway would be the last resort. Okay, next slide. So maintenance of anesthesia. In our setting, usually it's oxygen with inhalational agents. However, oxygen with nitrous oxide 50% is also used. Inhalational agents common to our environment, halothane, isoflurane. But let's note that in patients with postpartum hemorrhage, use of halothane could further exacerbate that, because halothane is associated with uterine relaxation. So our choice of inhalational agent will also be important. And then challenges with inhalational agent that it's when given at recommended concentration could lead to fetal depression and relaxed uterus. Because as I mentioned earlier on, obstetric patients have a lower mark. So when you use the normal mark for obstetric patient, it could lead to these complications. And then recommended to use ideal concentration of the inhalational agent. Next slide. So maintenance also, there's the choice of giving a top of muscle relaxant, or you could leave the mother to breathe spontaneously, but that would be at the risk of using a higher amount of inhalational agents. Muscle relaxants like atracurium, pancuronium, all can be used. The monitoring of patient is done on all vital signs, including the ECG, when available. Then after delivery, you give your intravenous amnestic and opioids, because the fear is avoiding giving opioids before delivery of the baby is because it could go into the placenta and could go into the baby, and baby could be delivered with a lower APGAR score. So we avoid using opioids before delivery. And then oxytocin is administered to reduce uterine atony. Oxytocin is the first line agent given at usually 5 international units slow infusion. Rapid infusion has been associated with maternal hypotension, and this could be maintained either as infusion, or you could go for second line agents like misoprostol or ergometrin. depending on the maternal hemodynamics. Okay, next slide. Then extubation, awake extubation after differential suction under direct vision. Awake extubation because, as we mentioned, they are difficult airways, so we are more comfortable extubating them fully awake. Where applicable, also place the mother in a left lateral position with a slight head down tilt, and administer reversal agent neostigmine with your atropine. Monitor your blood loss, and then you continue monitoring the mother in the post-anesthesia care unit. Next slide. Then some complications, some statistics. Every day in the year 2017, approximately 810 women died from preventable general causes related to pregnancy and childbirth. Majority of maternal deaths occur in low and middle income countries, with 94% of all maternal deaths occur in low and middle income countries. Okay, next slide. Then maternal mortality. Studies show that the risk of mortality for general anesthesia is 16 times greater than neuraxial anesthesia, with hypoxia being the major cause from failure to secure the airway. And aspiration of gastric contents occurs up to 1 in 400 times in pregnancy, compared to 1 in 2,000 patients for general patients. Next slide. Some other causes of mortality will have, some complications also, hypotension, even though less common than seen in neuraxial, but can be present if patient was already hypovolemic prior to the surgery, or if patient has developed postpartum hemorrhage. Then anaphylaxis is also one rare complication, because 1 in 10,000 muscle relaxants, antibiotics are some of the agents that have been implicated. Then awareness is, of course, mostly before delivery, or in case of hemodynamically unstable bleeding women. Next slide. So some standard monitoring in obstetric anesthesia. So the 4 elements of basic anesthesia monitoring are oxygenation, ventilation, saturation, and temperature. So this multi-parameter monitor might look familiar. You can see that it is showing us some of the mandatory things that we must monitor for a patient under anesthesia. We have the pulse rate, the SpO2, non-invasive blood pressure, the respiratory rate, the ECG. We have the carbon dioxide and the temperature. Next. Let's note that a vigilant anesthetist is also more important than all of these. So you need to have, you might have all of this, but if your anesthetist is not vigilant, then the work done might be 0. Then for general anesthesia, ECG, SpO2, non-invasive blood pressure, and capnography should be checked for proper functioning, and they should be monitored throughout anesthesia and during monitoring the post-anesthesia care unit. Then for regional anesthesia, we also need to monitor the ECG, non-invasive blood pressure, and SpO2 before the procedure, and also at least 30 minutes after block completion. Then for procedural sedation, we also have to monitor ECG, SpO2, non-invasive blood pressure, and then capnography, especially when there's loss of response to verbal contact. Then for patient transfer, also ECG, SpO2, and non-invasive blood pressure with capnography for airway devices are also standard monitors. Next slide. Okay, so fetal monitoring Most commonly used tests are the partogram, serial ultrasonography, which is what is more applicable in our setting. Then serial umbilical artery Doppler flow studies and cardiotocograph may be available in some centers. Are all methods of monitoring the fetus. And then also of importance is also the PNAD stethoscope, the manual method of listening to the fetal heartbeat. So the cardiotocograph is a way of monitoring the fetus, usually after the age of viability in the uterus. And it basically measures the fetal heart rate in relation to uterine contractions. So if we can look at the upper chart, upper table, where it's trying to classify CTD trace features, when the fetal heart rate is between 110 to 160, with the view of more than or equal to 5 per minute, we assume that it's reassuring. However, it's non-reassuring when the fetal heart rate is between 100 to 109 beats per minute, with less than 5, variability of less than 5 for 40 to 90 minutes. And it's said to be abnormal when the fetal heart rate is less than 100 or more than 80, or with a sinusoidal pattern, or also with a variability of less than 5 for 90 minutes. Okay, next slide. So in conclusion, general anesthesia in pregnant women is associated with a higher risk of difficult airway and awareness when compared with non-obstetric population. Neonatal anesthesia is preferable to general anesthesia for cesarean section, for cesarean delivery, and is associated with less maternal and neonatal morbidity and mortality. Prophylactic measures to avoid spinal-induced hypotension are important to maintain uterine placental perfusion. So these are in the form of, giving your adequate preload, your 15 mils per kg, 15 to 30 minutes before citing your spinal anesthesia. Putting your patient in the left lateral tilt to displace the uterus. That's also explained by Dr. Paul. And then, as always, preparation remains a key factor in ensuring good outcomes. Thank you.
Thank you very much, presenters. Now back to the end of the session. So I will welcome some senior colleagues to share the experience before we go to question and answer. I saw we have Dr. Garcia. Can you please say something? Okay, maybe.
Hello. I think I should thank all the presenters for a good presentation. We are blessed with the review on how to provide safe anesthesia for obstetric patients. And I'm sure we had a good number of participants from all over Africa. And more importantly, the students, both nurse anesthetists and residents who attended. This was quite a revision, and also you covered a lot of new information that was refreshing. And I think it will go a long way to improving the quality of anesthesia provided for our pregnant mothers. In the chat, I see some comments. Some other people are providing pethidine intrathecally. If time allows, can the presenters go through some of these comments and clarify some of the issues that may not be straightforward? Otherwise, thank you so much for this nourishment of the brains. Asanteni sana.
Thank you, Garcia, senior colleague from Tanzania. I'm thinking if you have a senior colleague from Nigeria, Dr. Sadati, I don't know if he is around, he's always around. I don't see him. If you're around, please, Professor Sadati, can you please say something? Or General? Otherwise, I think I'll welcome presenters to and the panelists to give some clarification of the questions which I've said. And I will start with we have time is not on our side. I'll try to pick some of them. And we have, let's start with the one with the severe preeclampsia, with the BP of 180 of 120. What will be the, I think you were asking about the safe anesthetic plan. Anyone from the panelists who can reply this?
I can respond to that. Dr. Sweetbet, you are not audible, but you said somebody in the chat panel said, what is the way to go if somebody has a blood pressure of 180 over what?
Over 120.
Over 120, and they want to go to anesthesia. Yes. So that's a very good question and a medical interesting case. And it's not uncommon in our setting to see somebody with high blood pressure comes to our theaters and maybe demanding an emergency cesarean section or an elective one. So by all means, hypertensive, pregnancy-induced hypertension is a diagnosis of its own, and it's having its management. So the modality and selection of mode of anesthesia should be done in totality, not just on an incidence of finding that the patient has high blood pressure. But having said that, I think if the patient fulfill other criteria of going through neuraxia block, spinal anesthesia could be preferred. Although for patients with uncontrolled hypertension, such as this one, they tend to have hemodynamically instability during the operation. So you'll be dealing with episodes of hypotension and tending to severe hypotension. So if you select a technique, you should put that in mind. I think I've answered.
Thank you, Paul. And maybe Dr. Mohammed can help us with the dose of, someone asked about the dose of Pivacaine and isobaric in pregnant women, but also for those with a short stature. Mohammed, please, can you comment something on that? The dose for Pivacaine for C-section.
Okay, if Mohammed is not around, I can also reply to that.
Hello, I am around. Hello.
Okay, Mohammed.
The question is for short people, what is the dose of the heavy methane? Hello?
Yes. The normal dose and for short people, what are the considerations?
Okay. I think you have given a range of the heavy methane when you are using it. It's 1.8 to 2.4. So when you are giving it to shorter people with a less height, so you tend to go towards the lower dose. So from 1.8, you can use it. Some people are even using less than 1.8, 1.6. So you use the lower normal dose of the Pivacaine for this C-section. And of course, even if you are looking at the height, also you have to look also at the weight of the patient. So the weight and the height determines how much you give. Thank you very much. I don't know whether I am clear. Hello?
Thank you. I think it was. and I'm trying to, so we are 2 minutes past our time. Let me see if I can allow one question to be answered, and then we can go. Can I give a feeding at the prophylaxis soon after SAB to avoid hypertension? Anyone from the panelists?
Sorry, the question is, can I give ephedrine after?
Feeding as a prophylaxis soon after spinal anesthesia to avoid hypertension.
Yes. Yes, some people are using the ephedrine. Some are even using the ephedrine as prophylactic. They don't even use the IV fluid regime that you give as preloading. Some are given ephedrine as it, but we have to understand that sometimes when you use ephedrine, there is the tendency of this fetal acidosis. So, but it is being used.
Thank you, Mohammed. So there are so many questions. There are so many good questions. Unfortunately, with the interest of time, we won't be able to answer all of them. But we'll say thank you for those who have asked the questions. And I'm sorry if we couldn't answer your question, but we'll try to do our best for the next one so we can answer as many as possible. So I will welcome Maria to give us some remarks, and I think to close the session.
Thank you, Dr. Sweetbert. I will actually turn it over to Magdalena in 1 minute, but I just wanted to say that because there were so many great questions, if you can send your questions that weren't answered on the webinar to customers@gradienthealth.org. You'll see the email address on your screen here. We can connect you with our panelists to answer some of the questions that we weren't able to get to today. And with that, I will turn it over to Magdalena to close us out. Thank you.
Thank you so much, Tim, for joining. Thank you so much for our panelists. A good thank you for Dr. Zinat and Dr. Mustafa. Thank you very much for joining the team. Looking forward to working with you in future. As my colleague said, please feel free to reach us out in case you also want us to discuss any other topics under anesthesia or critical care. Just send them right to us. We are an organization that believes in not only technology for safe anesthesia and critical care that suits low and middle income countries, but also training is one of our fundamental pillars in Gradient to make sure that the machines are being used with a complete and total medical knowledge and sharing. So thank you very much, and looking forward to another session. Yeah, bye.
Thank you very much, Magdalena, for your remarks, and thank you, everyone. See you on the next one.